Hello and welcome. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and our program, Digital Slide Review and Sign Out, is part of the Digital Anatomic Pathology Academy, featuring the archives in that academy of interesting and classical teaching cases. So our case today comes from the realm of GI pathology. As you know, I enjoy GI pathology, and I'd like to share with you this case, which is a middle-aged person who had noted a bit of epigastric distress, and that led to some studies disclosing the presence of a mass in the wall of the stomach. From the radiographic studies, it wasn't entirely clear whether this was mucosal or otherwise. And so I thought that would be a good reason for us to review some of the differential diagnoses based on location within the stomach. So of course, we know that in the mucosa is where we usually encounter tumors and tumor-like lesions. And most frequently, these are carcinoma. But on occasion, we can also see lymphomas, neuroendocrine tumors, particularly in the setting of atrophic chronic gastritis. Although in that setting, of course, usually the neuroendocrine tumors are very low grade and nonspecific. And of course, mucosal polyps of varying degrees and varying types, including some of the heritable hamartomatous polyps, as well as adenomas and proliferative lesions. When we start to get a little deeper into the wall, the differential also includes several different entities. Gastrointestinal stromal tumor, of course, the most common lesion in that location. But we also should be thinking about vascular lesions like the glomus tumor, nerve-derived tumors like schwannoma, and of course, leiomyoma, smooth muscle tumors. Although these are surprisingly rare given the amount and of smooth muscle tissue that is present within the gastric wall. And finally, tumors that tend to be a little bit more located towards the adventitial side of things, but that can occasionally protrude into the wall or seem as though they may originate from the wall, includes things like fibromatoses, inflammatory myofibroblastic tumors, and then a variety of sarcomas, which can include liposarcoma, synovial sarcoma, and a host of other sarcomatous lesions. So let's take a look at our case, which was not deemed amenable. Mucosal biopsies were unsuccessful in demonstrating the lesion, and so the patient came to resection. If you'd like to look at the slide here, you just scan the QR code here, and you can view the slide along with me as you listen or watch. So here's a nice section showing the overlying gastric mucosa. And then the submucosa, a little bit of inflammatory tissue here, the smooth muscle coat of the wall, again with some admixed inflammation, and this nice stromal neoplasm here, which is mostly pink, has a variability in terms of cellularity and so forth. So let's start here with what we can learn by looking at the mucosa. Because I think this is not insignificant nor trivial. So here's a portion of gastric body. But as we look at this mucosa, note how edematous and slightly inflamed it is. And also note how there's this sort of dropout or change in some of the oxyntic mucosal glands. So when you see this in a biopsy, and particularly if you've got some of this inflammation here, you may be thinking or may need to be thinking about an underlying tumor that's causing some degree of compression or edema in this area. And that should be contrasted here, as we see here over the apex of the tumor, with what we see here a little bit more towards the edge, where there's less pressure and so forth, and the oxyntic mucosa looks much more normal. So that can be a very helpful thing if you identify it on a superficial biopsy, to not let them just stop and say this is nothing. Now, the other feature here, of course, is this characteristic inflammatory cuffing of this lesion, which is quite characteristic of this specific lesion and not found with the other lesions that would be considered in this differential diagnosis. As we come into higher magnification on this lesion, we can see that it's a fairly uniform mixture of spindle cells with slightly wiry cytoplasm. And as we look at some of these nuclei in particular, you'll see that there's a little bit of tapering towards the end of these nuclei, slightly rounded, not totally point shaped, but a tapered appearance. So maybe you'd say a little bit cigar shaped if you were a cigar smoker or something of that sort, would be a characteristic description, rather than a needle point or pencil point type of appearance. Looking through this a little bit further, you'll see we've got a few cells with slightly clear cytoplasm around them. These may be reflecting those inflammatory cells at the periphery, but not infrequently when you do a mast cell stain on these tumors, you do discover that there's quite a significant population of mast cells in these lesions. And here we see even a few admixed plasma cells and lymphocytes as well. So let's look at another slide from this resection. And here again, we see a slightly deeper, almost adventitial lesion, but still having its origin up in the muscularis. And then again, this very prominent cuffing of the periphery of this lesion with lymphocytes. Now, in this particular field, we'll note that there's a little bit of pleomorphism in this tumor, as we see here, some nuclear pleomorphism and variability, but it's not associated with any degree of mitotic activity. As we search through this, it's extremely uncommon to find any evidence of mitoses. Again, we see this sprinkling of inflammatory cells in the lesion, and maybe a little bit of variation in terms of edematous areas and so forth, but not much in the way of a true biphasic pattern necessarily. So we're not seeing what might be called Antoni A or Antoni B areas, but we're just seeing this very fascicular spindle cell tumor with fairly low-grade morphology, aside from this area which we've identified previously, where there's a little bit of focal pleomorphism in the nucleus. Another similar section, unrelated, different case, but same diagnosis. You can see, again, intramural location. Here's a little bit of the smooth muscle from the wall, and a very bland cytology, spindle-shaped cells, slightly rounded, tapering ends to the nuclei, and very fibrillar type of cytoplasmic appearance. So thinking about that differential that we've just mentioned, this is sort of the Mural differential, which includes GI stromal tumor, glomus tumor, schwannoma, and leiomyoma. I don't think we would classify this as a glomus tumor. It does not have that sort of appearance, no cleft-like spaces or anything. Could this be a GI stromal tumor? Could it be a leiomyoma? Well, your immunohistochemistries, of course, would be confirmatory, but I think the fact that we have the inflammatory infiltrate at the periphery, the cuffing, as well as the mast cells and occasional plasma cells, both point more strongly, along with the nuclear morphology, to a schwannoma. And so, in fact, the immunohistochemistry on this case was strongly supportive of that, showing positive S100 staining and negative reactions with CD34, possibility for solitary fibrous tumor, negative with GIST markers, CD117, DOG1, negative for ALK, and negative for Desmond or any of the actins. So this fits nicely. Now, these are much less common than GI stromal tumors, but they do occur. We've talked about the morphology. The vessels can be somewhat hyalinized at times. And this peripheral cuff of inflammatory cells is very characteristic. Now, interestingly, there generally is not a biphasic morphology as you might see in schwannomas elsewhere in the body. And so that clue, which keys you in the auditory schwannomas or in the other areas where you may encounter this tumor, will not be present. And likewise, you do not get epithelioid changes or mitotic activity. So then in summary, our final diagnosis is a schwannoma of the gastric wall. The patient resection should be entirely curative and do very well as a consequence. So I thought this was a nice case to discuss the differential, and I hope you enjoyed that. If you do, that you'll hit like. And of course, we want you to subscribe to the channel so you can catch the future releases of our upcoming videos. So until next time, thanks so much for joining me.